With the permission of the chair, I would like to proceed. A very good evening to all of you. At the outset, I am really privileged and I would like to thank our chairman, Bihar chapter, Dr. D.P. Singh, Secretary, IMA, IMS, Dr. Roma Yadav, President, Dr. Archana Jha, IMA, IMS chapter, and the organizers, IMA, IMS, East Zone. So, as we know that thyroid, I would like to make it really light for all of you. It's a post-lunch session, people drowsy, sleepy. So, as we know that thyroid disorders are very common and it's a commonest encountered. Even our patients know what dose and what drug of how much amount of levothyroxine should be prescribed to them. They already know it very well, and especially in this Google era. So we know butterfly effect. This thyroid disorders in women is my topic. It's a small gland with a big effect. A small butterfly-shaped gland which is nestled in your neck orchestrates an extraordinary symphony of bodily functions. Despite weighing only 15 to 20 grams, it regulates a hurricane of metabolism, growth, mood, fertility, and pregnancy outcomes. When the butterfly stumbles, the whole symphony falters. Every cell in your body depends on the thyroid hormones to function optimally. A butterfly flaps its wings in the neck and a storm appears across a woman's life. So women are around 10 times higher risk and likely to develop the thyroid disorders than men. The reasons are complex: hormonal fluctuations, autoimmune susceptibility, pregnancy demands, menopause transitions, all conspire against this delicate thyroid balance. So around 200 million people worldwide are affected. Females are, as I told you, 10 times higher risk, and the pregnancy prevalence is around 15 to 28%, especially the subclinical hypothyroidism. So it is a silent saboteur. The classic symptoms is persistent fatigue, unexplained weight gain, hair loss, brittle nails, cold intolerance, which is often sometimes misdiagnosed. Sometimes even our patients make a pointer, मैडम थायराइड टेस्ट करा लें क्या, ये तो लिख दीजिए, शायद मेरा वेट इसीलिए बढ़ रहा होगा. Often misdiagnosed as chronic stress syndrome, depression, anxiety, normal aging process, and lifestyle related fatigue. Overt hypothyroidism occurs in 1 to 3 out of every 1,000 pregnancies. Transient hypothyroidism in 6% of the postpartum women. Congenital hypothyroidism or cretinism affects 1 out of 4,000 newborns. Most common cause in pregnancy and postpartum Hashimoto thyroiditis. So, which is a chronic thyroiditis or chronic autoimmune thyroiditis, subacute thyroiditis. After the common reason for this thyroid failure can be a radioactive iodine ablation. Iodine deficiency is all over the world. India, sub-Himalayan belt. So Hashimoto thyroiditis is characterized by the production of antithyroid antibodies, antimicrosomal antithyroglobulin, which are antiperoxidase TPO antibodies. Treatment is levothyroxine, which is converted to T3 in peripheral tissues. Half-life is long, 1 week, and the dose is 1.6 to 1.8 micrograms per kg per day. TSH level should use to monitor the response of therapy. Levels to be checked in 4 to 6 weeks in patients with a history of prior. In those patients who are already having a pre-existing hypothyroidism before conception, that is, the doses increment by 30 to 33%, maybe 50% may be required, depends on the weight of the patient, the BMI, and the 1.6 to 1.8 micrograms per kg per day. So levothyroxine can be adjusted to 25 to 50 micrograms milli-international units. The goal of treatment is to maintain the TSH in the normal upper range using the lowest possible dose in order to protect the fetus from hypothyroidism. So now, as we know about the overt hypothyroidism, very common, can adjust the dose. The patient is already on the drugs and can manipulate and maneuver. This thing can easily navigate. But what is generally overlooked and ignored is a subclinical category. And this set of patients are usually missed, and we should know how to differentiate. Subclinical hypothyroidism represents the tip of iceberg. What lies beneath can dramatically impact reproductive health and pregnancy outcomes. So how we define it, it has got a normal FT4 levels with elevated TSH. So here the FT4 levels are normal and the TSH is only elevated, typically between 2.5 to 10 milli international units per liter. So I'm focusing more on this particular arena because this is one which is usually we need little sensitization towards it, and little emphasis has to be made. Sometimes it may be overlooked by practicing clinicians. So the patient presence usually may be asymptomatic or will present with vague non-specific symptoms, and it has got a significant adverse clinical impact on fertility, pregnancy outcomes and cardiovascular health. The root causes of the thyroid dysfunction is an autoimmune thyroiditis, Hashimoto Graves disease, which represent the common. Graves is a hyperthyroidism, and it is an autoimmune hypothyroidism with TRAB antibodies positive. And it represents the most common cause where immune system mistakenly attacks the thyroid tissue. The drugs which are incriminated and implicated are amiodarone, lithium, certain cancer therapies which may disrupt the normal thyroid function. Iodine deficiency remains a major cause in developing countries, affecting about over 2 billion people globally despite fortification programs. I don't know what this fortification program, more and more fortification, and we are landing in more and more hypothyroidism. Only physicians can answer why this phenomena and this paradox is happening. Environmental factors, radiation exposure, obesity, advanced stage, and environmental toxins contribute to thyroid dysfunction risk. So whom should we should know who are at most risk and know the profile of those patients. It has genetic predisposition is responsible for 5-fold autoimmune clustering in type 1 diabetes, celiac disease, other autoimmune conditions. They also significantly elevate the thyroid disorder risk, reproductive history, somebody with a recurrent miscarriage, unexplained infertility or previous pregnancy complications. This warrant a thyroid screening. Age factor, women over 30 years face exponentially increasing risk, particularly during perimenopause. So listen to the whispers before they turn into screams. So fatigue, just stress is not the reason. It may be something undercurrent. So persistent exhaustion dismissed as busy lifestyle. You must look into, probe into, pry into. And the weight gain, poor willpower, not that. Unexplained weight gain. Again, I'm pointing towards the subclinical variety. The mood changes, emotional instability, depression, all these can be a pointer. Menstrual issues, the normal variation from the normal again can be a pointer towards the subclinical part. So a balanced thyroid is the first step towards the cradle. Optimal thyroid function before conception dramatically improves maternal fetal outcomes, making preconception screening essential for reproductive success. Maternal hypothyroidism untreated will lead to low IQ, growth restriction in developing babies, affecting lifelong cognitive development. Subclinical will increase the risk of miscarriage, preeclampsia, preterm birth, complications. So mother's thyroid is a baby's brain. Now this is one entity which is often met, and usually what happens in the first trimester is the patients coming at the TSH of very, very low, around 0.001 kind of, and with having a lot of hyperemesis and palpitations, weight loss, all these symptoms, but do not get minded for a hyperthyroidism, because this is the spillover effect of the beta HCG, and this has got an HCG connection. I even have seen long back 2 prescriptions of neomacazole on this, which I just dismissed, saying it is a transient one and it will settle on its own once the patient moves into the second trimester. So during early pregnancy, surging HCG levels can trigger temporary thyrotoxicosis, manifesting as severe morning sickness, weight loss, heart palpitations. The condition is typically self-limiting but requires careful monitoring to distinguish from the Graves' disease. So across the lifespan, from menarche to menopause, the butterfly never sleeps. So mental health impact is also there. Hypothyroidism presents with depression, cognitive fog, memory impairment, and can persist for years without proper thyroid evaluation. Hypothyroidism may manifest as anxiety, irritability, mood swings, often misdiagnosed as primary psychiatric condition. So early thyroid screening can save years of ineffective psychiatric management and improve quality of life. So one case study, a 31-year-old with a history of 2 consecutive miscarriages seeking preconception counseling. Her lab findings reported TSH 4.2 with a positive TPO antibody indicating subclinical hypothyroidism with an autoimmune component. So the treatment with levothyroxine was initiated at 50 micrograms daily with monthly monitoring and dose adjustment. She delivered a healthy baby at 38 weeks of gestation with normal birth weight and development. So the diagnosis was a subclinical hypothyroidism with a TPO-AB positivity in the first trimester. And the goal is to maintain thyroid trimester. We have the trimester-specific thyroid ranges, TSH levels. In the first trimester, it is 2.5. In the second, it is 3. The upper level is set at 3, and then it is 4 beyond that. So early diagnosis, timely intervention, healthier pregnancy outcomes. So she was continued on 50 micrograms of levothyroxine until term. The regular monitoring in second and third trimesters were done. An optimal thyroid control was obtained. Thyroid function remains stable at TSH 1.1, 1.3, FT4 1.6, 1.7. No complications during pregnancy. Full term vaginal delivery at 38 weeks. So a well-managed thyroid disorder can transform outcomes for both mother and the baby. So the clinical evidences, the numbers speak. There is a 3 times increased risk of the placental abruption, higher risk in untreated subclinical hypothyroidism, 1.8 times increased risk of preterm labor. It's a very, very important data. And increased likelihood without proper thyroid management, and 15% increased risk of low birth weight babies, which is higher incidence in the maternal thyroid dysfunction. Fetal brain development shows direct correlation with the maternal thyroid hormone availability during critical developmental windows. So the meta-analysis evidence is that subclinical hypothyroidism significantly linked to pregnancy loss, neonatal death, preterm birth across multiple studies. Benefits of treatment demonstrates a clear reduction in the miscarriage rates, preterm birth, gestational hypertension. A small pill makes a big difference. So it has got a very strong connection with the PCOS. There's increased prevalence of the subclinical hypothyroidism women with the PCOS, as the meta-analysis revealed, and it included the 3-fold higher risk of subclinical hypothyroidism in women with PCOS versus patients without PCOS. Subclinical hypothyroidism risk was 3.59 times higher in women with PCOS versus those without it. So Indian studies on PCOS corroborate the rising occurrence of PCOS, with the prevalence of PCOS in India ranging from 3.7 to 22.5%. The prevalence of subclinical hypothyroidism in Indian PCOS population was 22.5%. So understanding the link between the subclinical hypothyroidism and PCOS, obesity and insulin resistance play an important role in the mechanism of the PCOS and subclinical hypothyroidism. Excessive BMI is known to enhance this effect. Abnormal fasting glucose insulin resistance were more likely. A compromised immune system. Due to the anovulatory cycle in PCOS, the level of the progesterone is nearly zero. This enhances the stimulatory effect, activity of the estrogen on immune system, leading to higher incidence of autoimmune diseases. The strong direct interaction between thyroid and ovary has been implied by experiments both in humans and animals. For example, thyroglobulin and TSH receptor are detected in bovine luteal cells by immunohistochemistry, suggesting that luteal cells of mature corpora lutea may be involved in the synthesis of the thyroid hormones. A simple case again. 31-year-old presented to her obstetrician during first trimester, history of 2 miscarriages in the past 18 months. She tested positive to TPA-ABS, but her TSH was within trimester specific reference range. She had not been on any thyroid hormone supplementation therapy during previous pregnancies. A thyroid profile was performed, TSH 4.2, free T4 1.3 nanograms, TPA-AB 105. So subclinical hypothyroidism with TPOAB positivity in the first trimester of pregnancy, levothyroxine 50 microgram per day for optimal control of hypothyroidism was started and evaluated, further followed up, and then so what do guidelines say for levothyroxine for subclinical thyroidism, hypothyroidism in pregnancy? European Thyroid Association Guideline 2014 recommends treatment with the levothyroxine of subclinical hypothyroidism that develops before or during a pregnancy. American Thyroid Association Guideline 2017 recommends intervention with levothyroxine during pregnancy for TPOAB positive women with SCH and TSH above their trimester specific ranges, TBOAB negative women with SCH and TSH above 10, and here between 2.5 and 10. Levothyroxine may be considered during pregnancy for TPOAB positive women with TSH above 2.5 but below the upper limit of their reference range. TPOAB negative with TSH between the upper limit of reference range and 10 should be considered. So again a case 3, here we had a primary infertility, again unable to conceive 6 years, and referred to an IVF specialist. Previous investigation did not reveal any signs of thyroid, PCOS dysfunction, hyperprolactinemia or any other hormonal pointer. Before the IVF procedure, before embarking onto it, she underwent a detailed hormonal profile which included a TPO test. That is, I think now it has become mandatory because we have been neglecting this very entity. Now I have also made a panel in which I have incorporated, apart from the FSH, LH, TSH, MH, AMH and prolactin, a TPO-AB. So this has become important. Because it is a great pointer, because we may pick up normal ranges but they might have this autoimmune phenomena and autoimmune entity with them, and they may be benefited out of this borderline TSH high and free T4 and TPOAB. If it is 77, I think we must initiate treatment. So the primary infertility case planning for IVF diagnosed with subclinical hypothyroidism with thyroid antibody positivity, levothyroxine 50 micrograms per day for optimal control of hypothyroidism, and patient was asked to follow up with the TSH evaluation. So subclinical hypothyroidism is associated with poor outcomes in ART. Subclinical hypothyroidism negatively affects outcomes of artificial reproductive technologies proportional to the increase in TSH levels. Untreated SCH affected the pregnancy outcomes in women requiring IVF, such as decreased pregnancy rate, failure of implantation delivery rate, perinatal outcomes are worse in women undergoing IVF if their preconception TSH levels are above 2.5. That is important to take notice of. So it improves. So this case 4 is again with the menopause, and now to make so what is new right now? How will we go back? I mean, it's not going back. So the gold standard is the levothyroxine. Synthetic T4 replacement remains a cornerstone of hypothyroid management, providing consistent hormone levels. Precise monitoring is important. Dose adjustments every 4 to 6 weeks. Speaks on TSH level. Pregnancy safe. FD category A medication. And first trimester target should maintain TSH less than 2.5 during critical early pregnancy period for optimal fetal development. So avoid three important steps, three important warnings is selenium research is going on. Avoid over supplementation. Iodine supplementation is important. ATA guidelines, American Thyroid Association 2017, treat subclinical hypothyroidism and TPO-AB positive with TSH 2.5, above 2.5 for optimal pregnancy outcomes. European, it says initiate treatment for subclinical hypothyroidism detected before or during pregnancy to prevent complications. RCOG 2023 treats severe subclinical hypothyroidism, TSH above 10 immediately, monitor milder cases with regular follow-up. Who should be screened? High-risk women require screening, reproductive challenges, autoimmune patients, all those females with an autoimmune history and family history, previous irradiation. So essential clinical pulse, always think thyroid. Consider thyroid function in cases of unexplained infertility, recurrent pregnancy loss or mood disorders. Often over trimester adjustment is mandatory, and subclinical category has to be looked upon, and it is really, really important, which can be sometimes missed. So the ripple effect, as I sold it, butterfly flaps, and so important, and there is a tornado of disruption and complications. Disrupted ovulation, implantation, increased risk of complications, accelerated metabolism changes and fatigue, mental health. So thank you so much for the patient hearing, post-lunch